And very good morning to all of you. It's nice to see that the hall is nearly full, and I'd like to thank Dr. Krishna Prasad for teaching and refreshing some of the basics of refraction, keeping the crowd absorbed. I don't know whether I can meet up to the challenge, and also to prevent my optometrist from bullying me. Anyway, so I'll also be dealing with a very basic topic. So. Does anyone know the slit lamp is to an ophthalmologist what dash is to a physician? Exactly. So this is one of the most important tools that is in your armamentarium, and I'm sure that all of you are using them, these slit lamps, how a junior and ophthalmologist or how a junior student you are, because that's one of the first instruments as soon as you enter your residency. It is more important than all the hi-fi machines that you have for diagnosis, whether it be anterior segment or posterior segment. This is one of the most important and the most basic machines that you need, which can surpass whatever technology has to offer. So as you come up, you'll be using a lot of machines, many lasers, many optical devices, but nothing can surpass a basic torchlight examination and a basic slit lamp examination. So I have no financial disclosures, and even if I had any, I'm sure I'd lose it by my previous statement. So anyway, so basically I'll be dealing with the slit lamp not only as an instrument, because I'm sure you all are very familiar with all the parts of the slit lamp, what goes where, the viewing arm, the illumination arm, and how they are integrated with each other and the various other aspects of the slit lamp. My basic flow of the top is going to be on how the slit lamp can be used parfocally as well as non-parfocally. That is how you complete an ophthalmic examination using the slit lamp. Now, what is parfocality basically? Would anyone be having an idea on that? I'm sure you do. Yeah, so whatever, that is the basic definition. So the source of illumination focuses at the same point that you are focusing your attention on. So suppose you're focusing on surface of the cornea, that's exactly where the focus of the source of illumination, the bulb of the slit lamp is also. So that is called parfocality. Now the slit lamp can be used in both the ways. You can continue to maintain the parfocality and rotate around the same axis, both the illumination as well as the viewing arm. Or you can also use it non-parfocally. Can you remove this part of the image? Will that be more clearer then? Because I'm sure they can see me well. They don't want to see me then. Yeah, thank you very much. So now using parfocal viewing, you can either have a diffuse illumination, something like an elaborate magnified torchlight examination. You can have a direct focal illumination onto the object in the eye, onto the part of the eye that you want to focus on. You can have an indirect illumination or a specular, which is a specialized type of illumination requiring a particular technique to achieve the view. Non-parfocal viewing is basically used when you use retroillumination, what you also call transillumination, depending on what part of the eye you want seen, and also sclerotic scatter. So this is how you get to use a wide range that the slit lamp has to offer, not to mention the various other things like measurements, for example, tonometry, for example, measurements of lesions, even pachymetry, which can be done with the slit lamp, and extend your viewing to all the recesses of the eye, the angles, the part of the ciliary body, to the fundus, where your basic slit lamp examination is limited up to what part can you see? Anterior vitreous phase. So anterior 1/3 of the vitreous phase is what just the basic slit lamp examination is limited to. So I'll be basically using a series of videos to demonstrate what I want to say. So now this is a technique of parfocal examination that we usually do. So just to freshen up whatever we have forgotten, you see that the patient rests over here with the chin, the head rest. You try to make sure that this marker is aligned to the lateral canthus of the patient. you have this arm which the observer is using, and that is the observer arm or the viewing arm of the slit lamp, the other arm being called the illumination arm. So now you have both these at the same axis, and the illumination arm which she's holding, it now is the tonometer which comes in between. So the illumination arm and the viewing arm, they move at the same axis. So now this is parfocal viewing, and as you go along, you'd see that this arm is rotated depending on where you want the light to fall into the patient's eye. So it can go all the way nasally, all the way temporally, but at the same time, wherever it goes, it is at the same focus that the viewing arm is at. So that is what is meant by parfocal viewing. The next part is non-parfocal viewing. Now, very important aspect of non-parfocal viewing is are a couple of knobs that you should be familiar with that you don't use regularly for most of your examination. One is that round knurled knob over there. So that's one of the most important things that helps you lose the parfocality nasally and temporally. So if you loosen this knob over there, this one, what happens is that in the viewing arm, you can change the viewing arm a bit nasally or a bit temporally so that you can make it not confocal with the viewing arm. You can change the illumination arm a bit nasally or temporally so that you are not making it confocal with the illumination arm. So here is how this observer does it. So that's how the knob can be changed. Another important aspect is that thing over there. So that can be moved so that the illumination arm can be tilted vertically forward with respect to the vertical axis. So again, that changes the parfocality of the slit lamp. So this method is used for retroillumination as well as for sclerotic scatter. So here retroillumination is done where you try to align the arm along the patient's visual axis and try to get a reflex from the fundus or from the iris if you're viewing anything ahead of the iris. Here comes sclerotic scatter, where light is thrown on the temporal aspect of the cornea so that the whole of the cornea lights up like a fiber optic cable, and you can see a golden glow around the sclera. So these are the two systems of illumination where you use non-parfocality. And another aspect of retroillumination that I wanted to stress on, I'll be coming to the videos which use the retroillumination, is that it can be used at 2 points. One is the iris can be used as something which throws the light back. The surface of the lens can be used as something that throws the light back so that it highlights defects in the cornea. On the other hand, the retina also can be used as something that throws the light back, so it highlights both things on the cornea as well as on the iris. So what kind of defects do you expect in the iris? Just to name a few, which you can view by retroillumination very well. Excuse me? Yeah, transillumination defects of the iris, as in pseudoexfoliation, pigment dispersion. Then what else? Yes. Any other situation where you can have a transillumination defect of the iris? PI, very good. Something similar to a PI but not intended maybe. When do you get an iris hole? A foreign body, or maybe an iridodialysis, which may be traumatic or post-operative, unintended. So yes, very good. These are the situations where you can have a transillumination defect of the iris, which may not be owing to a disease process. Then another aspect that can be highlighted by transillumination on the lens could be, wedges of cortical opacities, posterior subcapsular cataract. Very good. So now this is what diffuse elimination is all about. So here in diffuse illumination, you throw light on the cornea. You're not intending to focus on anything in particular. It is for a diffuse illumination of the ocular surface, including the tarsal and the funducial conjunctivae, as well as the corneal surface in general. So this is to highlight any defect that can be grossly viewed. So it's a magnified or a glamorized torchlight examination, basically. So this is the same thing that's used to detect some sort of foreign body that may be hidden in the tarsal conjunctivae, or suppose you want to expose follicles or papillae on the conjunctiva. So this is the type of illumination that is used. Now here light is thrown on the cornea. The beam has to be broad, it has to be wide, but the illumination has to be lowered a bit so that it does not fall on the cornea. What do you see over here? Do you see something over here? What is that? I can just go back to the starting point. What do you see on the cornea here? What is that line that you see over here? It's brown in color, in case it's not visible. Any idea? Yes, what is a Hudson-Stally line? Iron deposit on the? Very good. And it's more visible with a blue filter than a green filter. A green has been used over here. It's more visible with a blue filter. So this is one of the iron line that is deposited on the cornea. The others being your Ferris line trabs, or those that follow the pterygium head. So these are things that can be seen by diffuse illumination. Diffuse illumination is also used in a common measurement that we do daily with the slit lamp, using cobalt blue filter, which is applanation tonometry. So we're coming to that. So that is also another system which uses diffuse illumination. So for using filters as well as for having a generalized view of the eye, it is diffuse illumination that's used in the slit lamp. Now coming to the second part, which is direct illumination. You want to see any part of the eye in detail, any lesion on the cornea, inside the cornea, in the aqueous, be it on the lens surface, or any part of the eye up to the anterior vitreous 1/3, it is direct focal illumination that is used. Direct focal illumination can also be taken as an optical section. So here there is a parallelepiped which is formed during direct illumination, which has on the anterior part, the anterior surface of the object you're viewing, on the posterior part, the posterior surface of the object you're viewing, and any opacity that happens to come in between. So in direct illumination, you use a narrow beam which is tall and well illuminated. So to reduce the discomfort, you start by seating the patient and throwing a very narrow beam that you can slowly increase in width as you go, and depending on what you want to see. So over here, when you have diffuse illumination, you can see that you're able to view the cornea, the aqueous, and furthermore into the lens. This is a semi-dilated pupil. I haven't gone up to the vitreous. Now, I want you to just have a look at this, and then keep this in mind while you're looking at the next video. And I'd like you to tell me what you're seeing over there. That also uses an optical section part of direct illumination, where the depth of any lesion on the cornea, or be it in the AC, you want to find out exactly how deep the cataract is, or what part it's located in, or whether if there's a foreign body lodged somewhere, where exactly it is, how far away from the lens. All that can be determined by an optical section, which can help you assess the depth of a lesion in the eye. So here, please have a look at that. This is very similar to what you saw before. This is an optical section through the cornea, through the aqueous, and through the lens. And as you watch, please keep on observing. Do you see a faint line in front? So what are you seeing over here? You can have an idea of the angle, and what was that object that you had over there? So what all are you seeing over here? So these are the various surfaces where light strikes and part of it gets reflected back to show you where you are. Now it's very clear in this picture. Do you see that line in front of the lens? What do you think that is? It's something to do with Dr. Krishna Prasad's talk. Any opinion? Yeah, that was a phakic IOL. So you had a phakic IOL sitting over there in the sulcus of the eye, that is between the, you see that small shadow there in front of the lens. So it's sitting there in the sulcus between the anterior capsule of the lens and the iris. So these are things that you're very likely to miss in an examination. There have been patients, like one of the patients that was presented was to me for my examination, had LASIK in one eye and a phakic IOL in the other. So you have to look for a phakic IOL if you're not used to seeing it regularly, or unless there's a lot of pigment deposited on it. Same thing, you have to look for a LASIK flap if you're not used to seeing it regularly, the margins of a LASIK flap. So these are the things that are going to daunt you. See, and you think a patient is perfectly normal, a young patient doesn't appear to have anything wrong. So these are things that you have to look for before you decide on the diagnosis. Another form of illumination is indirect illumination, where you're not actually illuminating the lesion you want to see. You're throwing light on side of the lesion. Now, this gives a glow to the lesion, because of which you're able to know its anatomy very well. So now, here, again, could you try to guess what this is? I'll just play the video. Let me tell you, it is on, now where do you think this is located? What part of the eye? Where is, our focus is that brown thing that you see, the brown spot you see over there. So where is it located? Any ideas? Pardon? No, it's not a foreign body. Where is it located, first of all? How many for the anterior chamber? No. Do you see a part of it in front of the iris over there? See, in the anterior capsule, you won't see that part, right? Which is in front of the iris. So it is on the endothelial surface. It is a patch of pigment on the endothelial surface. Now, what are the situations that can lead to such a patch on the endothelial surface? Yeah, any anterior synechia, okay, but such an imprint, the kind of imprint that you saw is unlikely. So what will cause an imprint on the endothelium, which is, an iris imprint on the endothelium like that? See, it is not pigment which is dispersed in general. It is an imprint of the iris on the cornea. Any takers? Blunt trauma. So if you need to have such a focused imprint on the cornea, it's usually traumatic. It's usually induced. Whereas all other, in other conditions where you get iris pigments on the cornea, be it persistent, a remnant of persistent pupillary membrane, the parts of which can be seen on the endothelium, or whether it be a pigment dispersion or KPs or whatever it is usually, or caused by a foreign body, it is usually diffuse. But this is an iris imprint on the cornea following an old blunt trauma that this patient had. So here it's indirect illumination, which is able to highlight the entirety of this lesion compared to the direct illumination that you see over here. So when we placed the beam just by the side of the lesion, that is when we are able to see it better, the whole of the lesion, than when it was directly on the lesion. So that is where indirect illumination has a role. Not only for the cornea, for any part of the eye that you want to view. So you have to choose your strategy of viewing, which is what I would like to highlight with that video. Now, coming to the next part, which is non-partifocal viewing. Sclerotic scatter is one such technique which can be used to detect subtle opacities of the cornea. So here what happens is that you throw a broad, wide, tall beam of light which is well illuminated on the temporal aspect of the cornea, and the light passes through the cornea, and here the cornea, there is total internal reflection from the cornea. So it's something like you do during gonioscopy using some of the Keppe lenses. So it's light which gets reflected between the anterior and the posterior surface of the cornea. So it goes up and down like that and comes out through the other limbus. That is why you see a glow all around the cornea in the scleral part. So that's when you know that you have achieved your technique of sclerotic illumination, sclerotic scatter. There is an angle that you need to maintain between the viewing and the illumination arm, which is around 60 degrees, as much temporally as you can keep. The beam has to be broad and tall and well illuminated, and it has to be thrown on the temporal aspect of the cornea, and you will see a glow, a golden ring all around the sclera, which shows that you have achieved the technique of sclerotic scatter. So now when such a scattering happens, any subtle opacity on the cornea, that is on the endothelium, any bedewing can be made out. So that is what sclerotic scatter was about. Going to retroillumination, which is another non-partifocal technique. Here you have a beam. Again, the instrument is disturbed in slightly nasally or slightly temporally or angled forward a bit, and it is not kept very separate from the viewing arm. The viewing arm and the illumination arm is very near the visual axis of the patient. For example, if you throw light from the temporal aspect of the pupil, you can view something on the nasal iris, but the angle between the two arms is not too large, so that you are able to get back the light which is directly reflected off the fundus. So retroillumination, and in the background of that light, you'll be able to see a lot of lesions or whatever small opacities that you have that may not be very clear by direct viewing. For example, here you see that you have some opacities here. You can see it's on the lens. But when you throw a retroilluminated beam, you can make out the posterior subcapsular cataract that also happens to be there. So which was not clear during the first examination. So now that is a relatively innocuous thing. But the other features that you may miss out on the cornea, like fine microcystic corneal edema, that is also much clearly made out when you see the small opacities on the cornea by retroillumination. Coming to another specialized technique of viewing, which is specular reflection. Now what this does is basically it throws light directly into the examiner's eye. So do you know of any natural phenomenon which involves specular reflection? Yes? Yes. That's one of the most common things that we see. Anything else in nature? Sometimes you see it on roads on a hot day. Yes. Maybe on a lake. When you have a dark lake and you have a sparkling area, the things that they capture in videos in all those channels, National Geographic and all, that sparkling effect that comes because of the specular reflection. Because of the whole area, there is some amount of light that directly reaches the observer's eye, and that is specular reflection. So that the same principle is used over here in the slit lamp. So you're throwing light onto the cornea, and it gets reflected from a particular point of the cornea with such intensity that most of the rays that come back from that particular space fall back into the observer's eye. So you're able to detect any fine irregularities in that space which is very brightly illuminated. These irregularities appearing at small dark shadows. What is the most important part of the eye that uses specular reflection? The corneal endothelium. So any fine changes like guttae or the margins of the endothelial cells, the hexagonality of the cells, all can be made out from specular reflection. The only constraint being that you have to get trained to use it. Now, let me just go into the technique briefly. It uses a very bright light, which is of nearly the same width that you use to check the AC flare in cells. So, round 2 into 3 would be a good size. Don't make it too tall, because then you lose the focus, the area of focus. And illuminating the illumination, the light where you focus should be very near the where the image of the corneal filament, the bulb filament falls on the cornea. So like here you have the light coming over here and the filament of the bulb appearing over here. So this is one way in which you can get a very good view of both the epithelium as well as the endothelium. And on the endothelium, you'll be able to see here. This is the picture which intermittently shows the shape and the hexagonality of the endothelial cells. So that is directly to know the health of the endothelium, especially say before cataract surgery or in a patient who may have a corneal dystrophy, or suppose you are planning to do LASIK in a patient. So these are situations where you would like to know the health of the endothelium, or maybe in a chronic glaucoma, so where you may use specular reflection. Now coming to some of the methods that uses the slit lamp to do other measurements include the intraocular pressure, where you use the prisms. You use a cobalt blue filter with diffuse illumination of very bright light thrown on the prism, and you try to equate, you try to bring the inner edges of the arcs together, as you all know. Then again, another special technique used is for aqueous reaction grading. So here, what effect, what physical phenomenon is required to grade aqueous cells and flare? The Tyndall effect. And what is the Tyndall effect? Because of the particles in the path that reflect it or scatter that light. Like you see light streaming through a window, and that beam can throw up the Tyndall effect. So it's a Tyndall effect that is used in this particular grading. And now here you'll be able to see a small beam of light that is thrown on the cornea first, and then focuses towards the aqueous onto the till up to the lens, and you can see the particles that produce the Tyndall effect flying in that beam. So do you see those small particles? This is a post-cataract surgery patient. So you see those small things lighting up like fireflies? Those are the particles that reflect, and this is used to grade the amount of cells that may be there in the anterior chamber, the amount of flare. It can also be used for grading the vitreous, the anterior vitreous, if there are any opacities, or if there is any sort of vitritis and something that has long been forgotten, vitreous flare that you see in sympathetic ophthalmia. So these are the situations where you use a small beam of light, 2 into 3 millimeters, focused on the medium that you are trying to get the Tyndall effect from, to find out whether there are any particles that reflect light or produce flare in that medium. Now this is a corneal ulcer, so I just wanted to highlight the various ways in which this ulcer can be viewed. So here you have an indirect illumination, so you can see the beam right next to the ulcer. Here you have a direct illumination. Another way to know the depth of the lesions, what part of the lesion. So here is an optical section which is going through the ulcer to know at what depth each part of the ulcer is, how much it has penetrated. And here is a retro view of the ulcer, which shows in general how the extent of the ulcer for an overview. Now here is something interesting. So as I have written over there, it's a phakic IOL. Now what do you see over there? it is both indirect as well as retro illumination. So there is that is the line of the phakic IOL in front of the lens. But what do you see over there? What is the hole for? Yeah, so it is a hole which allows the aqueous to come in from the posterior chamber into the anterior chamber, so that the ICL does not block the flow of aqueous. This does not require peripheral iridotomies. So this is the kind of ICLs that you are going to see implanted in the eye. Now here is another lesion, which is a recurrent corneal erosion. So again, I wanted to highlight how various types of illumination highlights the lesion. You see the lesion is over there. So it's barely seen, but by indirect or by retro illumination, it can be highlighted much more. Now this is an SF IOL that you see over there. Again, it is viewed in retro illumination. Are you able to see? Yeah, it's nearly over. Are you able to see this much of an SF IOL usually? You can see all the haptics stretching all the way to where it's glued. So why are you seeing this much of an SF IOL in this patient? Iris? Aniridia. This is a patient who had aniridia, had congenital cataract, had been operated on, and then he came for a secondary IOL implantation, and an SF IOL was done. So there are some other uses that I just like to remind you of. One is gonioscopy, like you can see over here. A 2-mirror is being used where the beam can be directed either horizontally or vertically to get a view of the angles. This is a 78D examination of the fundus, where the lens can be tilted a bit to get a better view and avoid reflections. This is an intraoperative examination of a LASIK patient using a slit lamp, where you're able to see the interface much better with the slit lamp view than through the microscope. So just to know that you haven't left any fiber or any extraneous deposits on the interface. Here is corneal marking using the slit lamp. So this is an ASICO bubble marker that you use for toric IOLs or for ICLs. So these are some of the other uses that can be used besides pachymetry, and a lot of others. I'm sure classes on that would be taken further. So this was basically a repertoire of how the slit lamp can be used for some basic measurements, how it should always be brought in. That's the first line of examination. You discover a lot of things using that before you go on to any sort of higher imaging modality. Thank you.